So this is our 19th foundation course in palliative nursing. We'll be having 18 sessions total for this program, starting from 12th December to 23rd February 2024. The class timings will be from 3 to 4:30 p.m. on all Tuesdays and Fridays. So the program includes a prescribed syllabus for nurses to understand practice in palliative care. We have shared the schedule for this program with you all. So kindly keep a copy of the schedule with you so that you can go through it and find out when the sessions are scheduled. And we have shared a pre-test questionnaire. I think some of you have completed the pre-test questionnaire, and I would like to request everyone to complete the pre-test by tomorrow itself. You will not be getting any chance to complete the pre-test after that. Pre-test completion is mandatory prerequisites for the joining for this course. So next one is about case presentation. We'll detailedly describe about that. So all the learning materials or resource materials will be shared with you all. And kindly, I think most of you have completed the IECO registration. All the learning materials will be shared through the IECO platform. So you can log into your own IECO account and download the learning material. So there will be a post-test questionnaire and end evaluation. And 6 assignments in total in between the program. So certification eligibility and mandatory clause, like a minimum of 80% of attendance in person. To ensure this, you have to keep your video on throughout the session. So a minimum of 80% attendance is mandatory to complete the program, and also completion of 6 assignments with a minimum of 70% of marks to each. So you'll be having 6 assignments in between, topic-based assignments. You have to get a minimum of 70% marks in each assignment. One assignment failed, you cannot get the certificate. And submission of one patient story. You'll be having a model patient story or case presentation today. And there are 18 topics for case presentation, which was shared by Mr. Sangeet to you. So you can select one of the topic and collect a patient's details and prepare a patient story and send it to us. And attending a pre-test questionnaire, post-test questionnaire, and end evaluation. Kindly note that these marks of this pre-test questionnaire, post-test questionnaire, and end evaluation will not be counted anywhere. So how to join for the sessions. We are conducting the sessions through an LMS named IECO. Each session will be having separate links for each participant. Like on a one-to-one basis, IECO will be sharing session links to you. So if you are using your friend's IECO link, you cannot get the attendance. So kindly ensure that all of you are using your own IECO account to join for the sessions. So if you are joining with your friend or both of you are using the same device, kindly keep your video on and give your name in the chat box so that we can ensure your attendance at the end. And the session links will be received by the email, WhatsApp, and SMS exactly 30 minutes before the session begins. Case presentation. Case presentation is also mandatory for certificate issuance at the end. It is in PowerPoint format. The PowerPoint format is shared with you all in your mail and in the WhatsApp. So download it and keep it with you. You will be having a model patient story today. Each participant needs to come up with a patient story among the 18 enlisted topics. So we will be having a case presentation from our end at the start, which would give you an idea of how to present. If you are not presently working or not having direct exposure to any patients, you can bring in any old patient story which you feel is relevant to the topic. So one of you will be presenting a patient story in each of the session. That will help you to get a practical knowledge on the topic. Learning material. Learning materials will be including the PowerPoint presentation by the faculty, session notes, and also the video link. It will be shared in the IECO platform. All the documents will be uploaded in the IECO platform. You can log into your own IECO account and fetch the details. And the thing is that we will not be sharing any learning materials through the mail or WhatsApp. Everything will be uploaded in the IECO platform only. And how to access IECO? I think we have sent invitation emails to all of you to the registered email ID. So you please check it. And if you haven't completed the IECO registration, please do register today itself so that you can get session links and also the learning materials. Thank you. So for further session introduction and faculty details sharing, I invite Mr. Sangeet. Over to you, Sangeet.
In the meantime, please ask the
I would request everyone to keep your videos on, please.
have any doubts, please ask if you have any doubts or need any clarification regarding this. Very good afternoon to all. Warm welcome to all of you for the 19th session on Foundation Course in Palliative Nursing. As Sangi said, today we are going to learn about the first session on palliative care. So we have an eminent faculty with us, Dr. Radha Venkatesan, who's basically she is an anesthetist and now she is a palliative care physician also. And she had worked Saudi Arabia and United Kingdom, so United States, and she has been worked since last 2 years with us. She is a palliative care physician. She is now our honorary palliative care physician. So she is one of the well-versed person in this field. Ma'am, welcome and over to you. Thank you.
Thank you very much, Shiba, and big thank you to Pallium for giving me this opportunity. And a warm welcome to all of you. Oh, there are some hands raised. Do you want to ask what if they have any queries?
Next.
Some of you have got your hands raised. Anyone wants to ask something, you can unmute and ask.
Okay.
Okay. Hope you've all come in to this platform mainly to know what is palliative care. That is the interest and eagerness is what has brought all of you together today. So hopefully we will try to impart the knowledge what is essential for all of you in the next 30 to 40 minutes. Okay. And as we go through, at the end of it, we will have time to answer questions or queries that you have. Or if anybody wants to ask in between anything, please raise your hand so that we can clarify then and there also. Okay, so first let us move on to know what is palliative care. So to start off, we need to know basically where from this word and the service information has come from. As with many terms in the medical field, this word has also got its origin from a Latin word pallium, which means cloak or cover. And the verbatim English meaning for that is to relieve without curing. So when cure is not possible, also there is another way of helping. That is care. If cure is not possible, at least care can be provided. So that is where from this word has originated. Next slide, please. Okay, why are we all talking about palliative care now? There should be some reason and need for it. So for that, like many years ago in the early 19th century or 1920s and 30s, what was the main problem for the whole world? Infections were the main issue. So those were tackled or solved by the invention of antibiotics. But in due course, where are we all here today? The main reason is today the main problem is non-communicable diseases. What are the non-communicable diseases? All of us are aware of, like diabetes, hypertension, dementia, renal failure, cancer. All these are non-communicable. They are not infection. The origin or the basic foundation is not, the cause is not infection. So this is what is there all over the world today. And it's not there in small numbers. So the statistics, what all the information that I've got up on these slides are from WHO statistics. So it is nearly 1.5 billion people experience some form of discomfort, be it pain or some form of end-stage disease. So that is the number all over the world. And so 61 million people, they say, so many, 1.5 million have the disease. Of that, 61 million people have some form of health-related suffering. So that is big number. This is a global figure. So if 61 million people need some form of support, then that means they are going to need some form of care also for longer term. So that is one of the reasons why everyone needs to be aware and start practicing palliative care. Okay, so when the number is increasing in down the line in 10-15 years time, the need may increase more. And the next important fact is for people to be aware is that death is something which is inevitable. Okay, but today's science and science down the line has made many advancements and improvement. So longevity has improved. That's a good thing. But at the same time, what do all of us want? We want quality of life as long as someone is alive. So if that needs to be provided, palliative care is something which has to be practiced to improve the quality of life of each one of or everyone in the globe until to the last breath without any burden. So that is why the need of palliative care is becoming very important. Next slide. So now we come to what does palliative care mean? What is the definition? Okay. Mainly palliative care is to improve the quality of life of patient and their families. This is something all of us have to understand and take it to its words content. So, and basically palliative care is for whom is it to be provided? It is for anyone with life-threatening illness. So what are the other things added on now? It could be a life-threatening illness, life-limiting illness, or any serious illness. So all these, this is how initially long back it was life-threatening. Now the other two terms were what I've said. What is the difference? Life-threatening means nearly the duration of life is going to be shortened. Life-limiting means what? Life-limiting means someone is not able to do what they are normally supposed to do. Okay, so there is some limitation in their normal living. Okay, and the third one, what did I say? Any serious illness. So for in that category, we will see in the rest of our slides that many diseases and conditions fall into those categories. So any one of this, be it be life-limiting, life-threatening, or any serious illness, all those three conditions may need palliative care at some stage of their disease. Okay, and next thing is that, is the illness going to be only physical? What all have we got to look into? So it could be a physical discomfort, psychological, social, or spiritual. So we have to look into all the four components. And the quality of life of caregivers also has to be improved. The quality of life of the person who is undergoing the disease and the quality of life of the caregiver. That is why initially it said patient and their families. In the second part, they have said caregiver. So we have to look after both. It could be one person or patient and one caregiver, or one patient or person with a family. So it is our duty to look after both. So these are the important elements from the definition which we have to keep in mind. Next slide. Next, where can it be provided? Okay, it could be provided in a hospital or at home too. We will see that in detail as we go through. Next slide. Next, little bit about the history. How did this all start? Dame Cicely Saunders is the pioneer for palliative care in 1967, like early, she started looking after people who were dying. It was not easy for her too. She was basically a nurse. And then with the amount of difficulty she had in providing care and things, she took all the effort to become a doctor and then started palliative care. Okay, so she is the founder or the pioneer for the whole palliative care all over the globe. Okay, next slide. Next, you'll see a timeline. How did it start and where is it now? So in the 1950s, it was Dame Cicely Saunders who started it, and with great effort, she started practicing. And then in the 1960s, it was Elizabeth Kubler-Ross from the United States who was trying to impart this knowledge and information to everyone. Even that was not easy. So she wrote a book on death and dying, in which she elaborately revealed what are the problems, benefits, stages of all the components of death and dying. So through that, people were more aware. And then in 1974, it was a surgeon by name Dr. Balfour Mount from Canada who coined palliative care, the word palliative care, because in the 50s and 60s, when these two great women tried and struggled, they could actually try to do what care patients needed. But then that also was not taken up easily. So then in 74, coining this word palliative care happened by Dr. Balfour Mount in 74 in Canada. And from 2006, globally, like initially in the United States, like proper qualifying in palliative care started in 2006. And at present, where we are in India, all over India, there are courses and certification available for people to gain knowledge and skill in palliative care. For example, you have master's degree, fellowship programs, and other 1 year or short-term, long-term, different varieties of knowledge imparting courses are there all over India. Next slide. Why do we need to do all this? Because end of the day, we want to deliver that service to the public. We want palliative care to reach each one and everyone all over India. So that is the main aim with which we are trying to move forward. Then what are the fundamental aspects of palliative care? Next slide. Why do we need to do this service? We need to provide pain relief and relief from other distressing symptoms. Why pain relief? Pain and breathlessness are said to be the most common. They give a number that 60 to 80% of the patients whom you will be seeing will be having either pain or breathlessness. So these are the most common symptoms which anyone in palliative care will have to face and deal with. So that is the first goal. So to provide pain relief. Next one is what? Affirm life and regard dying as a normal process. Okay, because death is another phase of life. So that has to be slowly imparted. So how can that be imparted? By raising awareness. Okay, and the third point is the important thing, because there are some myths and wrong notions which has to be understood first by us and imparted to everyone. Palliative care, the main thing is that there's no intention to either hasten or postpone death. I'm going to repeat this word again because everyone needs to understand this, and the myth is that it is understood wrongly. So basically, in palliative care, there's no intent to either hasten death or to postpone death. So both should not be done. Why? Because in the previous sentence I said it is a natural process. So providing care and symptom relief is the main aim and goal. So by that, hastening or postponing of death will not happen. And what is next? Physical, the first few things what we were dealing were physical symptoms. Next, what have we got? We have got to deal with the other psychological, spiritual aspects of patient care too. So a patient is a total person. Physical symptoms are part of him. He or she also has psychological and spiritual aspects also. So that is why there's something called as provision of total care. Okay, that has to be kept in mind. And what are the other aspects? It offers a support system to help patients live as actively as possible until death. So, if their pain and main symptoms are relieved, they should be able to look after themselves and do their own activities. Only if someone is not able to do their own personal, like activities of daily living, that is when they're upset. They feel helpless, they feel hopeless. All that can be taken away if symptomatic relief and also the other social psychological support is also provided. Next slide. As I said before, it is giving true complete support to the patient and also help the family cope with the patient illness. And when the stage comes to the stage of death, we also have to support with bereavement also. And how are we going to do all this? You do this with a team approach. We use a team approach so that, as I said, we need not only a doctor and a psychologist. If for financial support, I think we may need a social worker and a social worker team to help us to. So the whole aim or aspects could be approached and dealt with only if we adopt a team approach. Because main thing is that, see, by now you would have understood I'm talking about many components. So there are many aspects to this. So if there are many problems, how can we deal? Only with a multidisciplinary approach or multimodal management. See, these are words which you will see whenever you see, read, or look into anything about palliative care, because it's a multimodal approach, multidisciplinary. That means what? Multidiscipline. Doctor, nurse, social worker, psychologist, physiotherapist. So all work together as a team to give the best care to the patient and the family. So that's what. So the whole thing always it works around patient and family. Okay. By doing all this, what are we going to get? Will enhance quality of life and may also positively influence the course of illness. See, always there's no rule that someone has to struggle and suffer only. Okay. If all their problems are solved, will they not be happy? So can we not provide that? So that is what, these are the queries should come into each one of you today. Okay. If I can provide, why should I not provide? Okay. So that is why, so it will, for example, I'll tell you through the, so far, if anyone has any doubt or anything you want to ask, please do either unmute and ask or raise your hand. Or you can even type in the chat box. See, both options are there. And one thing, more queries you ask, more benefit for all of you. Okay, I'll tell that once again too. Because if you're all going to have doubts and hesitation in asking, you are only going to lose. We don't want you to do that. Okay, please feel free to ask, either like if you can unmute and ask or raise your hand or type in the chat box. Any one of this is fine. Okay, utilize the opportunity. Okay, and what I'm going to tell next, just I'll give you an example of a patient history. 38-year-old man who was the breadwinner, who is the breadwinner. He has 2 young children, 8 and 3-year-old. Wife is a housewife only. Suddenly, he's been diagnosed with a malignancy or cancer. And that also has affected him it is some oral malignancy. So personally, he's unable to eat, he's lost weight, he's not able to go to work. I'm giving you all this to keep in mind all what I'm telling. I'm going to give you the history alone. Then we'll go through and then we'll see how we can tackle. This is just a insight for all of you to think as one whole person. Okay. So just to reiterate, 38-year-old, breadwinner, unable to go to work because of his problem, diagnosed with oral malignancy, has two very young children, one child going to school, another child not even ready to go to school, and wife is a housewife. Okay, keep this in mind. So what all can go in his mind and what are the problems that he will be facing? Okay, next slide. We saw how, to whom, and where all. Next, when should palliative care start? Okay, if it is applicable that if it is started early in the course of illness, and how? In conjunction with other therapies. Other therapies which are given to intend or prolong life, which could be chemotherapy, radiotherapy, any form of treatment. That is curative management. And the palliative care also works along to manage the distressing clinical complication. We will represent that through a graphical representation through our presentation itself. Okay. Main thing, it is better if it is started early. That is the main thing you need to keep in mind. Next slide. See, this slide, I've brought it up here because to know what are the common proposed trajectories of dying. Okay, because this one, if you understand this, will give you an idea what all patients will need palliative care and what are the types of patients that you will be seeing. The first graph, this is the point. Oh, sorry. You keep it on that and give it to me. And this one only, no. Yes, thank you. See, you can all see the first where my pointer is there, no marker. See, that is a graph where you see on the left side you have function and on the bottom line you've got time. So basically it denotes someone who is having a very high functional ability. Okay, all through he's maintaining that. And suddenly it's dropping. Okay, common example for this is anyone can have sudden death, accident, something like that. Normally very good example, what many of my teachers have said is, good example is Dr. Abdul Kalam. Okay, he was actively working, talking, he dropped down dead. Only 7 to 10% of the population are blessed to die like that. Okay, so, and next common occurrence is this type. This is called as waterfall effect. You all know waterfalls. From top, water flows down. From such a height, it will just drop. So, but it is, you see, it is not like this. There is here also the time factor is less, but it is dropping down. The functionality is what you have to see. The functionality is still high, but suddenly it drops down to it drops down drastically. A very good example for this is malignancy, cancer. Okay, because till diagnosis, they would have been doing everything. No help required. I was doing everything by myself, but suddenly the condition can change. So this one, very good example is cancer. And the percentage normally they say is 15 to 20%. So 15 to 20% of the population can fit into this type. Third one is this one. Okay, this is the common one where big number will fit in. What are the diseases and things? All non-communicable diseases when they go into end stage. End stage renal disease, end stage cardiac disease, end stage pulmonary disease. Any system you can take, any end stage disease will fall in this category. Important things to note. See their function. In 1 and 2, you saw their function was high there. Whereas C, the function to start off itself is slightly lower. Why? Because these diseases have already caused some impact on the person. Example is cardiac. You take a cardiac, respiratory, or metabolic, like diabetes and things. What happens? The same 75-year-old who has no medical issues and take a 75-year-old who has medical issues. Just take diabetes, because now diabetes is rampant all over the world. You take a 75-year-old who has diabetes, okay? What will happen? They will not be the same as a 75-year-old who does not have diabetes. At least some kidney impact, or eye, some cataract already done 15 years ago, or some retinopathy I have, or I have at least peripheral neuropathy, I have pain in all my extremities, something like that. So their function is already less. And this one, every dip you're seeing here are each admission to hospital. So after each admission, they will go low and they will come back. Yes, that is the wonder of science today. Everyone will have some form of treatment, ICU management, everything will be there. Yes, they will come back. But see, after the second admission, going down, coming back, this one functionality has come here. Already there is a dip in functionality with the second admission itself. So if someone is going to have 3 admissions in 6 months, 1, 2, 3. So at the end of 3, where? Here it is. See, where it started, where? Within 6 months, 3 admissions means how much? If the original start of function was 60%, they'll be in 30%. Half of that they are. So these are things to understand. First, we have to understand and then impart it to the patient and family gradually. So these are all also our duty. So this forms 50% of the population. Okay, so these are things. That's why normally they say, oh, he walked into the hospital, but he went out in a wheelchair. Why? Not that his hand and leg is not, he didn't have any stroke. Just, he could have had a pneumonia. But his functionality is going down because there is some amount of decompensation in all systems. Okay, so this forms a big number, and all end-stage disease, we will be seeing many patients. Not only me, all of you. See, all of you, if anyone disagrees with anything that I'm telling, please feel free to unmute and say or type, because we are here for discussion only. Okay, so this forms 50%, which is big number. And then the last one is frailty. 80, 90, 100-year-old. We are all seeing many 100. I have even seen in home visit 103-year-old. Okay. So what happens? See, the function is very, very low. And the decline is also very low and gradual. So this forms 10 to 15%. Okay. So this is something, or it is better that all of you understand. And if anyone wants to ask anything, any doubt in these 4, these are the 4, set as the 4 trajectories of dying. If anyone wants to ask anything, please do ask. I'll give you a minute or so that if you have any doubt, you can clarify with this before we move forward. Okay, then go to the next slide. So next is life-threatening illness. As I said, I gave an example of cancer with that patient also, but not a rule, it should only be cancer. It could be neurological, respiratory, cardiac. It could be any system, okay? And if you take any system, what I've given on the left side, if you see on the right side, all these components could be there. It could be physical, social, psychological, spiritual, or patient specific, or family specific, anything. All components can be there for all the diseases that are mentioned. Okay, next slide. We'll try to see a little bit of each. Okay. So what are the common physical things could be there? Pain, what I've listed there, all of you can see on the left side. So these are the common physical symptoms and aspects which can happen. And how are we going to manage these? Again, as I said, you have to manage by dealing with the physical symptom. And that's why I've said multidisciplinary. You have to convey to them. They'll all be worried. For example, take cancer or cardiac patient. No, for them, their appetite will be less, their intake will be less. So because of that, no, weight loss will be there. Why is it happening? Partly because of the disease, partly because of their psychological impact. So it is our duty to explain to both the person and the family. The person is unable to eat, family wants to take care. See, but they are in opposite ends. So if you explain to the family the condition of the patient and give them option, not only explain, if there is a problem, you have to give solution also. An example I'll tell you, a cancer patient, okay? We all know cancer patients have loss of weight, loss of appetite. So they can't eat. And the carer and family are providing, they want to give so much love and affection, okay? They want to cook everything, whereas the person cannot even does not want to eat. So what you have to do there, give them the advice on giving small, frequent meals, not big, large 2 meal a day. Okay, so this is what I'm trying to say. You have to see the problem and give solution also. By doing so, you are solving the problem of the person and the family. You're giving solution for both. So they can have a happy relationship. No, they won't be fighting with each other. Because the person is unable to eat because of the disease and his condition. So if they give small, frequent meals, the person will also try. And the person who's the carer will also feel satisfied. Oh, this is the way I have to do. Okay, problem solved. And they may have not a rift relationship or disagreeing in everything. They will agree and have a better quality of life. So that is one of the examples, as I said, that has to be done by good communication, good information, and telling things properly. And the next thing what I mentioned there is slowly, as you gain rapport with the person and the family, what you just have to do is you have to explain the condition of the person and what are the forthcoming things that can happen. Pre-warn them, prepare them, give them all the information that they will need to face and anticipate. Okay, why are we doing all this? So that every minute, as we said, the whole life, dignity and quality of life is maintained all through. That is the main aim. Till the last minute the person passes. Okay, next slide. Psychosocial aspects and spiritual aspects, how are we going to do? Normal psychological, what I mentioned, no, everyone has some fear, depression, helplessness, worthlessness. I cannot do anything. I'm a burden to everyone. That is what everyone feels. But on the other hand, the carer wants to look after. Okay, so that is where some counseling, psychological interventions, if it is done, that will be very helpful. Appropriately, it has to be done. And this all will need time. Okay, so that's why you start, identify, pick it up early, it can be done properly. And coming to spirituality related issues, first we have to assess what it is, and then we have to give due respect for everyone's belief, concepts, religion, local religious beliefs, local cultural systems which is followed. Respect everything, okay? And try to see how you can help. So get appropriate help that that person needs from their cultural background. Okay, and never force or assume or give any philosophical advices. Okay, because that is not what they want at that point of time. Try to do what is essential and what is useful for that particular person and family. Next slide. So from now, so having heard all this, what is the aim of palliative care? Is to support the patient and family wherever it may be it hospital or home, and to improve their quality of life and enable a dignified death. So we provide care till the end. Next slide. Now then, okay, I'm telling all this as though it's very easy. Now we come, what are the barriers? Why are we not able to achieve all this? So the barriers are there in different levels, and we'll roughly see what are the barriers and what's common. National level, we have some issues like, see, there are no standard health policies. Now only slowly palliative care is being introduced, and everyone is not trained. So now we have got full bunch of all of you getting trained. So once you all get trained, you can go train more people. So like that, healthcare professionals, training itself never existed. Slowly it is happening. So that is one of the barrier which is trying to be overcome. And then next is that to a great extent now, pain relief medications are available, but even international, global WHO figures say medicine is there, but it is not reaching to where it needs to be available. For example, I'll say big cities may have the medicine. Okay. Do all rural villages have the medicine? That is the next thing. How are we going to take it to the place where it is needed? So for that only all of us are striving hard to do, and hopefully we will work together to reach a day when the medicine is also available to the person who needs it. Next slide. Next is lack of awareness among policymakers. Okay. Sometimes the professional may know, but as I said, national barriers. No, sometimes the people who need to know may not be knowing. And among healthcare professionals also, there may be some myths and things. So all these have to be overcome by raising awareness. And as I said before, cultural and social barriers will be there, but we should not fight against it. We should go along with it and see how it can be improved. And still there are very many misconceptions about palliative care, that it is only an end of life care. These are things. Hospice is only palliative care. No, hospice is an element of palliative care. So these misconceptions have to be slowly broken away. Only by repeated awareness and training that can be overcome. And again, about opioid also, just one word I would say, through the sessions you will all learn more. But one thing is that when opioids are used for recreation, the way they are used itself is different. Okay. For example, when it is used for recreation, it is either smoked or used as an intravenous IV drug use. That is when the bad effect of it comes out. Whereas when we use opioid, we use it for pain relief. When pain is in its peak, and when you give opioid, it will not have the unwanted effects which we are always aware of, like dependency, those type of things will never happen, because that's what opioid is the gold standard for pain relief, for cancer and many such situations. And in the last 15-20 years, when it has been used so extensively, when there is intense pain, the relief only is obtained and the bad effects are not seen. Okay, that alone I would like to highlight here. And as you go through the other sessions, you will all gain more knowledge on that. Next slide. So next, we saw the barriers. How can the country and nationally we can overcome all this? that like palliative care system could be made as part of health system through integrating that and starting or implementing policies and giving separate financial funding and having a structural training. All these could be done so that at all levels, at professional levels, and making sure that from teaching itself, all this is happening now all over the world and to a very great extent in India too. Okay, it has been incorporated into the health system curriculum, and not only for health professionals, volunteers, public awareness, volunteer training, all that has to be done. And Pallium, as part of their mission, all these are done. There are training programs for volunteers, for doctors, nurses, allied professionals, everything is there. So all that. So these are the steps. And this is how it can be done. And that's how everyone is trying to implement. And next, medicine policy, making sure that medicine is available first, and then making sure that it reaches where it needs to be. Next slide. And what's the significance of palliative care next? Next slide. So as we said, it is effective when it is started early. And when it is started early, it will improve the quality of life. And the last part in this slide is important. If it is done appropriately, it will reduce unnecessary hospitalization and unnecessary use of healthcare services. Okay, that is one of the aim and goal also. So if it is done properly, what type of care is needed will be provided, and unnecessary hospitalization, unnecessary use of healthcare. So there won't be wastage. Okay. So if there's no wastage, the same funding can be used for the care and quality of life of the patient and family. Next slide. So this is the diagrammatic representation which I was telling. So basically, if you see in this graph, see this point, presentation diagnosis, okay? That is when one person is coming to the hospital. So at that point, they don't know. They have come with all their investigation test report, okay? So they are in the process of finding out what is their disease, where am I, what have I got to do? Okay, if palliative care is introduced at that point itself, that is the best. See, you have this portion, because patient does not know, no? They are having test biopsy, one biopsy, second biopsy, frozen biopsy, this biopsy, that result is not. This all happens. I am not creating stories. All of you will be knowing. And especially when a diagnosis is made, we have to make sure that the diagnosis is perfect. Okay. So even at that phase, see here, disease modifying therapy, curative, life prolonging. So radiotherapy, chemotherapy, any therapy you put, that's all happening here. The white part is corrective therapy and the yellow part is palliative care. Okay. So both work hand in hand. When curative therapy is contributing a bigger part, palliative care is going there slow there. How can palliative care help? For example, chemotherapy, radiotherapy. Okay. They have a load of patients to do. They will be giving chemo and radio, but patients will have so many side effects. So those times symptom management can be helped by the palliative care. Counseling, psychological, those can be helped by the palliative care. Okay, then in all good interest for the patient, everything goes well, remission achieved, very good, continue the same. That's also fine. So there, what support can be given will be given. But unfortunately, treatment tried, 5 chemo given, no response. Disease is still progressing. At that stage, here we are. When this curative therapy is not very helpful there. So see, at that point, palliative care takes a bigger part. Okay. So this is what I'm telling, going hand in hand. And after that, what happens? Okay, curative therapy not work. So comfort care, supportive care is going on. Their final phase, this is when, see the small bit, that is end of life care. That, as I said, that is where hospice and things can come in. Okay. And then palliative care doesn't stop there. We go on further. Even after the patient passes away, the family will have grief. They will have to come to terms. Now I will come to the case that I told you. Okay. Take that 40-year-old. Okay. Initially here, we give full treatment for that person. 38-year-old, I said oral surgery, radiotherapy, everything is having. Driles to put in for feeding. All that helped to some extent. Okay, fine. Some 2 years, 3 years down the line, some more metastasis found. Okay. So still, his treatment may or may not be helpful. At that point, you have to keep in mind, he has a family, 8 and 3-year-old children. They need to go to school. They need to pay, he needs to pay fees. And he needs to make sure that the wife and children live. They need financial support. He was the breadwinner. Okay, there are so many components. So we need to provide total care for him. So that is where all these together. So that is what, see, support, control, supportive care, symptom care, everything. So this has to work hand in hand and multidisciplinary also. So this is what all of you have to understand. And then after death also bereavement. For any situation you take, you have to look into how will the family survive after the person passes away too. They may need more support there also. Okay. And this one cannot be provided by one person. It has to be a team. You may have to involve the other community involvement, other NGO involvement, some groups which are willing to help. There are many groups willing to help. You have to link and join. Okay. So that is where all these are important. So next slide. As I said, pain and breathing are the common problems. And for that, opioids are very helpful, both for pain relief and for breathlessness. All these, don't want to overload all of you in day one, but as you go through, you will be finding out morphine and opioids are very useful for many problems, and they would be very handy if used appropriate. Next slide. So now just a small information on what is hospital-based care and what is home-based care, because that also, see, in palliative care, you're going to have many patients who cannot come to the hospital. Okay. Not that they don't want to, they are physically unable to come. Someone is bedbound, no energy, not able to walk. How will they be able to come? So it is a burden not only for the person, it is a burden for the family to bring them in too. So that is why you need to be aware of both hospital-based care and home-based care. So we'll just see a few points, the plus and minuses of both. So if it is hospital-based care, all I've been telling, multidisciplinary, everything is there under one roof. Come into one big campus, go from one building to another building, you will see all psychologists, social worker, physiotherapy, nursing care, everything. All are available in one place. So that is one type of care. You just move from one place to the other. Next slide. Another option is home-based care. As I said, why? I already told why and where it is provided. And only thing is that you need to prepare a home care team for it. So again, multidisciplinary, you can have a doctor, nurse, social worker, psychologist. And again, for that, it all depends on your resources. Every time you may or may not be able to. For that, I would say it would be utmost importance for all of you to come and see in Pallium what happens. Okay. Here every day, 7 teams set out at 9:15 or 9:15 to see. So they cover so many areas. And many times all 7 teams will have a doctor, may or may not. That is decided also appropriately, not just because there's no doctor. So there will be patients who will need to be reviewed. Then that team will have a doctor. One team is going to see patients who have been seen by a doctor. They need review. So that will be seen by a nurse and psychologist or social worker. Okay. So like that, don't think the quality of care is not the same as in hospital. If you have a well-trained multidisciplinary team, you can provide care in part to hospital by home care also. But you have to prepare, anticipate, and get everything ready. Resources are a big important thing in such provision of care. Next slide. What are the importance of home care? See, there are two columns. One is from patient's perspective, and the other one is from carer's perspective. Patient's perspective, in all of us will be happy at home. Will we be happy in a hospital? New place, I would prefer to be in my chair, my bed. So like that, the environment, I would like to be in a place which is best for me. And next is to have, you will have your son, daughter, grandchild, everyone next to you. That is what you want. And you gain so much confidence being at home. Anyone. Okay. So those are the benefits from patient's perspective. From carer's perspective, all carers want to provide love and affection. So they are able to do that because they are at home. In many places in hospital, one person only can stay. One will be inside, one will be outside. For example, 4 people come, all 4 cannot get in. So from that point of view, the family as such going to be happy. Physical, social, psychological, coming to hospital, I have to spend money. All those issues are all solved. And by providing home care, no, continuity of care can be provided. Utmost care to what level is required can be provided by teaching the carers and the people who are going to be looking after what is needed. Okay, next slide, please. And how can we succeed in all this? Next slide. So basically, as I said, all these by providing awareness, information, and also giving them the utmost important information in a very nice way. So communication is a very important thing, which will be dealt with in great detail. And also telling them, giving them good ideas and teaching them what they need to know by little bit of role play and things, which we can all do. We are all experts. We can achieve and convey the information. Next slide. So these are just the important, because communication is a very important element. So how good you can communicate, you will be dealt with separately. But these are the cornerstones. The information has to be clear, correct, and complete. And it should be concise. You should not be telling stories. And if you tell stories, they will forget the important thing. So it has to be concise and appropriate, coherent. And finally, it has to be courteous. You should not put rule. I am telling you have to follow. That doesn't work. Okay. So we have to convey things properly in a nice way so that they are willing to accept. They will accept and follow. All what we say, we want them to follow. No, just not that we say and then nothing happens. That is not what we want. Okay, next slide. So finally, what are the learning points? What are the take-home messages? So early involvement of the multidisciplinary team will be the vital role to give complete patient satisfaction and well-being. And patients should be given full autonomy. You should ask them what they want, what is their wish, and try to find out. And also keep it confidential. So that only then, if you keep it confidential only, they will respect, and we also have a duty to respect their wishes. Okay? And early involvement of other disciplinary teams will be helpful in all aspects so that you maintain and deliver quality of life. And family and caregivers have to be given important. They have to be informed, looked after. Everything has to be done from the beginning. So, and the main thing is that it is important to treat distressing symptoms at the end of life too. Not only when someone is in distress, when they are fully fine. Till the last minute, it is our duty to provide good quality care and give them a comfortable time all along. Next slide. Thank you very much. Thank you for patiently listening. And anybody wants to ask something, please go ahead.
So thank you, ma'am, for the excellent presentation. Anybody need any clarification or any questions, please ask, madam. So we would like to see you all. Please switch on your videos. Okay. So if you don't have any questions, I will ask few questions. So Madam has shared many things today on palliative care. So my first question is, why the patients come to us? The next question is, what they are expecting from us? And the third question is, what is the role of a healthcare provider for us, for nurses? What is our role? So I would like to hear from you all. You can unmute yourself and talk, or you can put your answers in the chat box. So I hope my question is clear to everyone. We all nurses. My first question is, why patients come to us? Why? And the next question is, what they are expecting from us? And the third question is, what is the role of a healthcare provider, or like a nurse? We all nurses. We are waiting for your answers. What they are expecting from us. Lily ma'am said to take proper care and to relieve symptoms. Okay, thank you. Any other answers? Patient.
Ma'am,
Yeah, yes. Go.
myself Priyanka from BLK. Hello. Ma'am,
Yes.
you are asking why patient come. The patients are coming to get relief from physically, emotionally, to get their health good.
Okay, thank you.
Yes.
Any other answers?
Hello.
Okay.
Hello.
Yeah, Vishnu.
Ma'am, my name is Vishnu.
Yes.
I already worked as a palliative nurse in Government Medical College, Kollam.
Yes.
Now I am moved to Government Medical College, Pathanamthitta, Komi. Work as a casualty nurse.
Okay.
In my previous experience, in 2012, I already got to FCPN.
Okay.
Then I worked in government, Sri Gokulam Medical College, Venyaramur. After that, I got to government job. I start my career in Government Medical College, Trivandrum. This year also, I joined in palliative as a nurse in Government Medical College, Kollam. Hello.
Yeah, Vishnu.
Is it clear?
Yes, your voice is clear. So the question. I hope.
Actually, here is one range problem. So now I am in duty.
Please put your answers in the chat box so that we can able to see.
Okay.
Okay.
Actually, in our palliative OP, many patients came to, they have a lot of expectations like to their physical care and emotional care and their social care and the economical care. I mentioned so many times this such type of patients. Our palliative team is well established in Government Medical College Kollam.
Okay.
One of the doctor, his name is Dr. Yadav sir. He also well managed. I support with him.
Okay, Vishnu.
Patients have a lot of expectation like physical, spiritual, and the social and economical support. Some patients is very poor in our government sector. They are coming to lot of expectation.
Okay, thank you. So thank you for your answers. So my first question was why patient come to us. So we know if someone develop an illness or incurable illness or a curable illness, we will try all non-pharmacological management first, right? Then we will take some medications from the pharmacy, generally. And then if that all fail, they will try to come to the hospital. Okay. So when they come to us, what they are expecting from us? They are expecting some care from us. So there we need an empathetic mind because we don't want any sympathy. That local persons can say something. As a healthcare provider, we need an empathetic mind to treat because what is empathy? We have to place ourselves into their place. So that is empathy. If you have an empathetic mind, definitely we can able to treat their 4 aspects. Like Madam has already mentioned, this palliative care is a total care, physical. We all focusing on physical care, and also we have to think about the psychosocial distress. If they have a psychosocial distress, their physical problems will increase. The intensity of the physical distress will increase. So we all or that nurses are spending more time with the patients. We are the apt person to find out the problems. And also, Madam has mentioned about the teamwork. We are not able to handle all psychosocial issues, so that you can include a medical social worker or a psychologist into the team, and that person can be able to explore their psychosocial issues, and we can able to try to able that solve their problems. If you are able to solve these kind of things, definitely we can able to improve the quality of life. So our main aim is to improve the quality of life, right? So if you are able to reduce their sufferings, sometimes physical sufferings, sometimes psychosocial sufferings, sometimes spiritual sufferings. If you are able to reduce their sufferings, definitely we can able to improve the quality of life. And the third question is, what is the duty of a healthcare provider? To mitigate suffering. So our duty is to reduce their sufferings. So we have a good heart and we have a good assessment knowledge. So when a patient comes to us, we need to assess them well. Okay, so if you do a proper assessment, you can able to find out their problems and you can able to treat them accordingly. Okay, and also Madam has mentioned about the importance of home care. If they are able to come to us, if they are able to walk, they can come and take the palliative care treatment. If they are not able to come to us, what they have to do? We all in the hospital. When they come to us, we will be able to treat them. So in a point of times doctor will be saying like nothing more we can do. They have to go back. So who is the primary caregiver? The person, the family member is the primary caregiver, is that person when they go back. Are we demonstrate all procedures to the caregivers? That all things we have to think. When they go back, who will give palliative care? So when they are not able to come to us for a bedbound patients, we are ready to give a home care support. So we need to provide a home care support. And also we need an inpatient settings, because sometimes some problems we are not able to manage in their home. So that time we will try to bring the patient into the inpatient unit and control their symptoms and send them back, and educate the caregivers and empower the caregivers to how to take care of that problems. And then they have to go back, and our home care teams will be giving a follow-up. So that's how the palliative care team working. And then, so after death, so palliative care, madam already mentioned about the palliative care. When is the ideal time to start palliative care? So ideally, it should start from the point of diagnosis along with the curative management. And definitely the person need end of life care, and also you have to think about the family. You have to always, the patient is also, palliative care is for patient and their family. When a patient get an illness, like a life-limiting illness or a life-threatening illness, the whole family will be affecting, right? The person, the primary caregiver is the most vulnerable persons too. So like that person is the vulnerable person to suffer from the point of diagnosis till death. So they need to go to the hospital for curative treatment, and also they have to go back and do all the household activities, and then also they have to look after the patient. And also this is how the family member is working now. So we have to think about the patient family also. And after death also, you have to provide a bereavement support. So after death, we have to give a psychological support to the patient family. You have to visit the patient family. And if you are not able to go to the family, you have at least to give a phone call and talk to them, that they are okay or if they need any help. So that is how palliative care is working. So I think we can move on to the, madam, do you want to add anything?
No, I think basically that's what, see, put things together, and then as Sister Shiba has said, practicality, so knowledge, service, everything together, then you will be able to do good service.
Okay, so we can move on to the patient story. Sister Reshma is with us, who is a senior palliative care nurse, and she is heading the home care service department. She will be presenting a patient story today. This is, as I mentioned earlier, this is a model presentation. After that, one of you have to present a patient. Next session onwards, you have to present a patient story based on the session. So welcome.
Good evening all. Today we are discussing a patient story of 39-year-old male diagnosed with traumatic quadriparesis with stage 4 pressure sore on sacral region and the left gluteal region. About the presenting complaints, patient complaints of constipation since 2 days, bed sore over sacral region and the gluteal region, complaints of moderate pain over the hip region and urinary leakage was there. About the history of presenting illness, he had history of fall while carrying weight followed by neck pain and weakness of both limbs, and was diagnosed with traumatic quadriparesis in August 2015. Patient admitted and got treatment from one of the government hospital and discharged after 1 month. After 6 months, he had developed a bed sore over the sacral and the gluteal region that was stage 4. History of pain over the hip and wound side for more than 2 weeks. Pain over the hip region bilaterally. The pain was intermittent in nature and burning type of pain. And the pain score was 5/10. And also complaints of pain at the wound side. It is continuous in nature and throbbing type of pain. Pain score was 4/10. Due to this pain, sometimes patient keep the wound open. Also complains of disturbed sleep pattern and decreased oral intake. Examination include at the time of admission, patient was conscious and oriented, and all the parameters are within normal limit. And about the pressure sore, patient complains of warmth and tenderness, exudates present, then tunneling. The tunneling was present, and the bed sore is irregular in shape and foul smelling. And after treatment and significant investigations are done, some routine blood investigations done after the admission. That time HP was 10 and total count 34,000, and others are within normal limit. About the psychosocial aspect, 39-year-old unmarried man living with his 65-year-old mother in a rented house. He has one sibling and he is married and living separately and not caring and helping them. He was a manual laborer and was the breadwinner of his family. Now, his mother is a manual laborer and she is taking care of him. Now, the main source of income is from mother's daily wages, her pension and some of his friends. Have taken rupees 1.5 lakh from private finance bank for the treatment purpose. They are devout Christian, now unable to go to church. This makes him very sad. He communicates through cell phone. He says to his mother like, I don't think I can walk. So please don't spend money over my treatment. The main concerns are pressures of pain and the financial problem. And 39 summary include 39-year-old man with traumatic artery paralysis with bed sore, stage 4 present on sacral and the left gluteal region with pain over the hip region. And the discussion points include, the first one is, do we need to provide palliative care for this patient? And the second discussion point is what are the problems faced by this patient? And last one is, what all can be done for this patient and his mother?
Thank you, Reshma, for the wonderful presentation. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. Anybody? So I hope this presentation is clear to everyone.
This is how you all have to start preparing. Okay. This is just like a sample one. Why? Because so from now on, you will have every day you will have a topic for your day's discussion. And all of you are working. Even if someone is not working, when you were working, you would have seen some patients appropriate to that day's topic. So all of you have to start preparing and sending in your case presentations based on, this is just like a sample for you all. So please, if someone has any questions, please ask now. So that if you don't ask questions, we are going to be anticipating flooding in of case presentations from all of you.
Okay, thank you, ma'am. So do you think this patient need palliative care?
Yes, the patient needs palliative care.
So what you say is?
Already, patient suffering from traumatic artery areas and bed sore 4th stage. He is in bedridden patient, and their financial status is very poor.
Okay.
His wife is not care with him. His mother is only care with him, and she is the only income lady in his house, income earning lady in his house. So the patient must and should be provided palliative care.
Okay, thank you. Any other opinions? So I think you all agree this patient needs palliative care because this patient need a life-limiting illness, bedbound, and as Vishnu has mentioned, some financial problem is also there. So definitely he needs palliative care. Okay. So we can move on to the next question. What are the problems faced by this patient?
You can go by physical, social. See, utilize what you heard today itself. So someone, either one person can tell one issue or one person can tell. You can answer keeping those 4 elements in mind. And all those are there already there. So someone can answer based on that. So use that framework to answer the question.
Namaskar, ma'am. Good evening, ma'am. My name is Diya from Max, New Delhi. Ma'am, the patient is also facing the problem of spiritual also because as ma'am
Yes.
told that he's not able to go to church properly. So like in the presentation, ma'am told like the patient is using the phone. So we can provide video calling to the patient so that the patient could feel like, yes, he is in the church or he could attend the church. Like
See, that's all. So one aspect you've seen. Other aspects, like all very good. First thing, positives first. You picked up the problem, and you are suggesting solution also. Exactly, this is what we are looking at. So, what are the physical, psychosocial? Already, Vishnu had mentioned.
He is suffering from traumatic orthopedic.
Exactly. Very good.
So he is already bedridden patient.
So psychosocial, what is the problem? What can be done?
In psychosocial, his mind is not clear. He is separated with his wife. That is one of the problem. And their financial condition is very poor. Only his mother, only the earning member in his house.
So some counseling can be given for him to elevate his
Yes,
mood.
some types of counseling will be providing for sociologists.
So first is counseling to be given to the person so that he doesn't feel bad.
Yes.
He's saying,
Yes.
don't spend much.
Social worker.
Correct.
Yes,
Social worker
social
to
worker.
help with financial things, counseling to help him feel
Yes.
better. So like that, no, each problem,
Yes.
try to look at solution. So, and physical, we have seen he's got
And physical
ulcer.
needs, he already he is getting for 4th stage of bed sore.
So proper skin
So
care.
daily dressing and
Yes.
daily
So
he needs daily dressing.
correct. So that's what all aspects, physical,
Yes.
dressing, then skin care, teaching the mother also how dressing could be done.
The
So those
other
are things.
other
Career
physical aspect,
education.
he is not walking. That is one of the major problem is his mind.
So that's all. Physiotherapy, nursing care,
Yes.
counseling,
care.
every element. So all what you heard today are coming up in this case itself. Okay. So
Yes,
see,
yes,
this is how you put 2 and 2 together. You heard the whole information and you've got a case where you can put that into practice straight away. Okay. So
Okay.
dealing with all the 4 components, each taking up the problem and looking at probable solutions for that. Okay, someone has Bushra, anything you want to ask?
Connecting. Yes, Ganga.
Ganga, go ahead. If somebody.
Can you hear me?
Yes.
Ma'am, he has psychological problems also. He said like he don't think he can work. So please don't spend more money for him.
What shall we do for that?
He need. Hello.
Can hear you.
we
Go
can-
ahead.
He needs psychological support, psychological counseling.
So, if a person says
And
like this, yeah, continue.
And he need more income for their daily living.
Okay, thank you. So usually the patient or a caregiver say like this kind of bit things, little bit things. But if you hear these kind of things, like he is saying to his mother, like, I don't think I can walk, so please don't spend money over my treatment. So this is a small sentence, no? So behind that, he has lot of problems inside his mind. So if you listen, if you hear these kind of things, try to explore his emotion, because what what he is understanding, and what other problems he is facing, that all things we need to find out. Try to include it. That's how the teamwork. You have to try to include a social worker or a psychologist into your team, that patient care, and try to explore the patient's emotional things, and social things, and spiritual problems, and maximum we will try to cover that problems. Okay, if we are able to manage it, try to manage, or like siblings. He has one sibling. He is married and living separately, so that is also emotionally affecting him a lot. Only the elder mother is staying with him, and she is also now she is doing some work like manual laborer, and also she is the person to take care of the patient now. So in morning time she will not be able to care in the house. This is a bedbound patient. Then you have to think about the physiotherapy. You have to add a physiotherapist in, if you have to add a physiotherapist in that patient care. So our aim is to make the patient independent as much as we can. So without support, we can not able to walk, but at least we can able to get up from the bed, or get up from the bed to wheelchair, and without make them independent as much as we can.
Then the third issue was how can you help the mother and the
So the third issue is what all can be done for this patient and the what's
you
mother.
said only.
Yeah. So we all these all things we already discussed, because here we have to find out if when a patient comes to you, these kind of things, you have to find out what are the physical issues, what are the psychosocial issues, what are the emotional issues, and what are the spiritual issues. And after that only we can able to give some kind of support. If you are not able to look into the psychosocial part, we are not able to help the patients. Always you have to think about the total care as total care. Okay, so you have to think about the total pain concept also.
Okay, our discussion points was, first one is, do we need to provide palliative care for this patient? The answer is definitely yes, as he is in a life-threatening situation. He has serious health-related suffering. So his quality of life is definitely affected due to illness. And palliative care is not only for cancer or end-of-life situations. It applies to any health-related suffering, and the above patient story is an example for this. And the second discussion point was, what are the problems faced by this patient? He has physical issues such as pain, bedsore, urinary leakage, insomnia, loss of appetite, etc. He has spiritual issues as mentioned in the presentation, and feeling of being burdened to the caregiver. There are financial issues, identity issues, foul smelling wound over his body, social isolation was there, loss of independence, loss of job, anxiety, and depression to be ruled out. And our third discussion point was what all can be done for this patient and his mother. Community mobilization for regular visits, fund generation if possible, and vocational rehabilitation for the patient and his mother. And empowering the mother to take care of daily care of him like position change, bed sore, dressing, etc. And any respite for the caregiver for few days to address caregiver fatigue. Look at the health issues and emotional issues of the caregiver and make him feel that he is useful, convey that we are care. We care. Thank you.
So, like previously. Because from this patient story, you all understand about the total pain concept and how all we can able to provide palliative care. So here, what can be done for this patient and his mother? We have done. We have find out a local volunteer to that person's nearest volunteer from that nearest place, and we motivated the volunteer, and the volunteer in between, he can able to go there and support the person. And morning time, usually the person go there and talk to him. Morning time, as we discussed earlier, the mother is not there, no? So that time the volunteer will be go there and talk to him, so that he like a social isolation. No, this is an isolation. He is not able to walk. Most of the time he is in the bed, so nobody is there to talk to him. So if someone is there, so that he can able to go there and talk to them freely, and he can able to explore his emotions. And so if they are able to explore their emotions, so what is next? So they can feel some kind of emotional and feel that ventilate. They can able to ventilate the feeling, and they feel some that like good mental relief. No, so so that kind of thing you have to think about. And vocational rehabilitation. So you have to find some these kind of vocational rehabilitation, and if you think these kind of things, the mother can be able to stay with him. And from that, we are that thing find some kind of that money is there. No, they can utilize that money for his treatment or daily living.
His family.
Yeah, so these kind of things always you have to think, and respect care also. So you can able to leave his mother as well, like at least 1 week he can able to stay with us on week, and the mother will be free, and mother can able to stay with her elder son for a week, so that she can also have get some relaxation. No, so that is the respite care. So always you have to look into the emotional issues of the caregivers also. Convey, we are here to support you all. Okay. Thank you. I think time up, we can.
Yes. Thank you, Radha ma'am, for the wonderful session. It was a detailed session. It was a proper introduction to how to palliative care was. And thank you, Shida ma'am, for facilitation. Thank you, Sister Reshma, for the case presentation. Thank you all for participating actively. Thank you. Let's see in the next session. Bye.
Thank you.
Thank you, everyone.